Good evening, everybody, and thank you, Claire, for hosting us. Well, friends, believe all are keeping absolutely fine. And today, we are having a special webinar created for the exam going postgraduate students. And it's not for the exam going students alone, it's for everybody. This is something which we want to do every 6 months regarding how you should appear at an examination. Even though you all know what to write, sometimes certain small things makes a difference that makes your examination appearance better, comfortable, as well as going to score more credits. And today is such a program. We're going to tell you through a very seasoned examiner. That seasoned examiner is Dr. Baljit Singh, otherwise the Chief Executive Officer of the college. And I proudly welcome Dr. Baljit Singh to do this particular webinar on examination, how to prepare, how to appear, and how you should present, and what is the way you should answer, and all those small things which sometimes we think are not that important, but what counts a lot, are going to be said by Dr. Baljit. Baljit, you know, is an examiner since our last 2 decades. Most probably, I believe he would have sat for at least 1,000 examinations in India, and that too with all the universities and the national board examinations. And he's such a creditworthy person who may be able to advise you how one should face an examiner and the examination. Before we start the webinar, I may like to say you something about our college. Our college, well, you know, started in 2008. We are in the 16th year and going very steadily. And we are involved in the academic activities. And this is an academic trust. Started as an appendage of Indian Society of Anesthesiology, but now stands alone as a separate academic trust which is promoting only academics. And we are, in addition to these webinars, all sorts of academic activities like conferences, one-day programs, short courses, well, national meets, publications like yearbook, journals, and conduct of short-term courses on certain areas which are not being done that very well in India. And we do all sorts of mentoring and academic promotion works. And if you want anything else other than this, kindly be in touch with us. We may be able to bring that also. The next great thing which is going to happen in 2 weeks' time is our multi-choice question answer examination, which we titled as Olympiad, where in 2 years' time, you will be answering 100 questions. And probably this question and the appearance examination is going to be a tremendous experience how to face an MCQ in future in India or outside. With these words, I request Dr. Baljit to start off. And I welcome our President, Dr. Jayashree Sood, who is here, and she will be addressing you after Baljit finishes. Baljit, please.
Thank you so much for your kind words, sir. I'm really honored to be part of this program. I'm sharing my screen. Sir, is the screen visible?
Yes, sir. Yes, sir.
Thank you so much.
Yes.
Thank you so much, sir. Well, this title is Dr. Radhakrishnan's suggestion. Postgraduate examination made easy and high scoring. Well, when we think of examination, most of the candidates appear to think of a situation like this. Appearing in the examination is an important milestone, and that may be life-changing experience. And to pass or to get through the examination, what you need is a good knowledge base, good skill base also, and a good presentation. Now, how to make it easy? You need three things. Work hard. Nothing comes without that. Work harder and work even more hard. There is no shortcut to working hard for preparing and appearing the examination. You must have a good knowledge base before you think of the practical examination. Now, how to make it high scoring? For that, you should have an impactful performance when you're going for the exam. Now, there's a great man of science, Albert Einstein. I'm sure you all recognize him. He said that everybody is a genius. But if you judge a fish by its ability to climb a tree, it will live its whole life believing that it is stupid. How true? Now, assessment parameters have to be appropriate to the knowledge and skill of the assessing. It should be appropriate and relevant to the learning. The skills related to the application of knowledge for patient care and not beyond that. Now, if you are to define examination, what exactly it is? It's a process in which a medical student is evaluated by a superior, whom you call as examiner, for getting a degree to practice anesthesia. Now, during this process, the examiner determines whether or not the student is capable of conducting safe anesthesia independently. Now, if he is convinced that you will be able to conduct safe anesthesia for a given problem, you get good marks. And in case, despite your knowledge, howsoever knowledge you may have, but in case he feels that your conduct will put the patient to unsafe situation, well, the things may be difficult for you. Now, why examination? You might say that, we have worked so hard in the last 3 years, done ICU duties, attended all the classes, emergency duties, whatnot, ran around quite a bit, this investigation, that investigation. But you must know that examinations are essential components of teaching and learning. Without an examination, it is just not possible to know whether the students have learned and whether teaching has been effective and how best to improve the learning needs of the students. Now, there are two components of it, assessing and evaluating. Assessment is the process of gathering information on the student's knowledge, and evaluation is the process of analyzing, reflecting upon the information that the student has, summarizing, and then making decisions. Now, the scope of the examination is to test the ability of a candidate to assess a specified medical condition for conduct of anesthesia. This is basically for the practical examination. And the student is expected to take history, elicit physical signs, establish a diagnosis, and determine functional status of the patient. Scope of the examination also includes spot the diagnosis of some very obvious medical conditions, ability to interpret the common investigation like ECR, chest X-ray, ABG, blood tests, and pulmonary function tests. And he should also be able to evaluate the risk of surgery and anesthesia to that patient. And then, of course, he should be able to discuss the management of any situation like acute emergencies. Now, how is the examination process completed? There are two components to it. One is the theory examination, which involves the ability to recall whatever knowledge that you have stored in your memory cells, organize that information and put it on paper. That's relatively easy because you're on your own. You think, you form an answer, write it on paper. Practical examination is an assessment of the practical skills, situational awareness, and the response to the given situation that you may be asked. And this may sometimes be intimidating. Now, why so? We'll come to that later. Just a brief about theory examinations. The general principles of answering the theory questions are very, very valid here also. You put the question number clearly on the left side of the page, space, give a space after you have completed answer to that question. Before you start the next question, there should be some gap. Or you go on to the next page, write bold headings so that your answer becomes somewhat clear. Clear handwriting, less said the better. Well, when you start your writing your paper, the handwriting is very good. When you come to the last question, well, the things may be different. Diagram wherever necessary. This is a very important component of your answering. Now, diagram doesn't need to be a work of art. You just draw, even if it's a caricature or whatever you draw, that's good enough. The examiner must know that the candidate knows. He is not looking at your art. He's looking at what the content of that diagram. Time your answers. It's very important. Generally, for DNB examination, there are 10 questions in the theory. And 10 questions means 3 hours, 180 minutes, and it comes to 18 minutes per question. I would suggest that you think of 15 minutes for each question. Don't cross beyond 15 minutes. You have to put your answers, you have to write everything within 15 minutes. It doesn't mean, sometimes I often hear from the students that, the paper was too lengthy. It's not lengthy. I mean, in the 15 minutes, you have to complete your answer. You don't write anything in detail. Just put headings, bullet points, enough for the examiner to know that you know the subject, you know that answer. But never miss answering any question. That'll be quite a heartbreak. You know it, but you could not do it. It's basically about the time management. Now, what are the key issues in the practical examination? It provides an opportunity to test skills of the candidate in a realistic setting, confront the candidate with problems he may not have met before, assess responsiveness and prioritization of actions to a complex situation. Well, let's say that a patient has come with road traffic accident. He has a fracture femur, it's an open fracture. He's bleeding from there. He also has airway difficulties. Now, if you prioritize addressing the fracture or the blood loss, well, and the airway is overlooked, I think then you are in trouble. Also, to test the ability to communicate under pressure, to be a part of the team who is looking after the patient, and to discriminate between important and trivial issues. What are the practical advantages of practical examination? That's for the for the examiners particularly. It provides one-to-one interaction. It provides opportunity to take mitigating circumstances into account and flexibility in moving from candidate's strong points to other areas. Now, if the candidate is answering very well, the examiner is convinced that he knows it. Now, he might shift the gear. He may go on to some other area. Just to know that it was not just a flash in the pan that you answered questions very well. You have an overall good knowledge base of the subject. It also provides opportunity to question the candidate how he arrived at the answer. Opportunity for simultaneous assessment by two examiners independently, two different settings. So it's not just one examiner, two examiners independently assessing the same case which the candidate has presented to them. It requires the candidate to formulate his replies without any cues. There are certain disadvantages too. The standardized conditions may be lacking. There may be cases of varying difficulties. There may be patients with varying difficulties of cooperativeness. They may not cooperate. You ask a question, he will, very briefly say, since when is the pain there? 6 months ho gaye, 6 months. He won't say any word beyond that. It lacks objectivity and suffer from intrusion or irrelevant factors. And there is limited time to assess the full potential of the student. And the examiner's approach may vary. Practical examination, as I told you earlier, usually the hardest part of the examination. There's a lot of anxiety. Howsoever well you have read, however times you may have gone through the whole book, but you still are having some degree of anxiety when you appear for the examination. It requires you to understand the question which the examiner has asked, think about that, formulate an answer, and then reply. And all this is while the examiner is looking at you. Now that makes it even harder. Now, appearing in the examination is quite stressful. We all know that. It's stressful because you are in unfamiliar setting, meeting strangers, and you're about to interact with persons who can change the course of your life. A few mistakes here and there, and you are in trouble. Now, how the examiners are for MD, there are 2 internal examiners. There are 2 external examiners who are from outside the hospital, outside your institution where you're working. And for DNB, all 4 examiners are from outside. You don't know, nor the examiners know you. They are from states other than that where the examination is being held. Now, how do the students generally imagine the examiners to be? Have a look at this X-ray. Take 5 seconds to just have a look at this. What do you see? I wish it were interactive. I'll give you a hint. Now, where is the heart? The students generally feel that the examiners don't have a heart, totally heartless people. And some even think of a situation like this, that they are chased by, whatever you call it as. I just want to dispel that myth. Examiners are not as bad as they are portrayed. They are as much humane and as much kind as any person that you know of. In fact, they are your friends. They want you to get through, want you to pass the examination. They'll give you a hint here and there where if you're stuck. But they are given a job and they have a responsibility to fulfill as honestly as possible. Well, love them or hate them, you have to face them. What do the examiners expect? They expect clinical competence during the case presentation, basic steps in the history, examination, investigations, differential diagnosis, and safe perioperative management of the patient. Now, if you have covered the basic points in your answers completely, you can expect to get good marks. The pattern of scoring varies from, for MD examination and for DNB examination. For MD examination in the present system, you have to pass the practical examination with at least 50 marks. That is true for national board also. In case presentations and viva. For MD examination, usually there is one long case of 100 marks, short cases of 50 marks each, that totals up to 100 again. Then there are 4 stations for viva, each has 25 marks, and it total comes to 300. The scoring may vary from university to university, from place to place. So this is a rough guide of the scoring for MD examination. For DNB, the pattern of scoring is different. There are 20 OSCE stations. Each carries 5 marks. That comes to 100 marks total. Then there are 2 clinical cases, which are actually an equivalent of the long cases in MD examination, 50 marks each. 4 ward round cases, which is an equivalent of the short cases that you have for MD examination, 15 marks each. That adds up to, that makes it 60 marks, and then 4 viva stations, 10 marks each, 40, and that again comes to around 300. This again, the score might vary a little bit. Now, what are the OSCE stations like? Now, these stations here, the question or the stem of the question and the subsequent questions are projected on a large screen while you're sitting in the hall. You get 4 minutes to write answer to each OSCE. And after the 4 minutes, that question will disappear from the screen and you will have the next OSCE coming up. So you have to complete your answer within 4 minutes. These OSCEs are run virtually, uniformly and simultaneously from the National Board of Examination and Medical Sciences Command Center in Delhi for all the centers across the country simultaneously. The command center monitors the conduct of the examination throughout the country, and the sheets, as they are collected from the students, they are immediately scanned and sent to the National Board of Examination within completion of 1 hour after the OSCE questions are done. Now I give you a sample of one OSCE station. You have a picture on the left side, and on the right side, there is a text. The stem of the question is that a 55-year-old man is brought with history of acute left hemiparesis of 12 hours duration. What is the finding and diagnosis on this brain CT? That's one question. Second is he a good candidate for intravenous thrombolysis? The third is, what surgical procedures may be required in him? And fourth is, what medication may be required to prevent recurrence of this condition? So that's just one sample of OSCE question that the National Board projects. In DNB, as I told you, there are two clinical cases of 50 marks each. The student is given 3 to 5 minutes for a quick history and quick examination of the patient. Viva lasts for about 20 minutes each case and with a team of 2 examiners. And these are, as I told you, that these are equivalent of long cases for MD examination. These are the kind of cases that you get in the ward rounds, 4 cases, 15 marks each. And these are the cases which have very visible diagnosis. You don't need to struggle much. You can ask 1 or 2 points, from the patient. That's it. Otherwise, the diagnosis is almost obvious. The Viva stations, there are 4 Viva stations, as I told you earlier, that candidate has to rotate through. One is anesthesia equipment that includes anesthesia machine as well. This also includes monitors, defibrillator, etc. The second is drugs, inhalation agents, and IV fluids. The third is resuscitation and difficult airway. And the fourth is the investigations like X-ray, ECG, ABG, capnography, and pulmonary function tests. Now, what are the kind of questions? There is no fixed format of the questions. Different questions may be asked for the same patient. So don't think that your previous students were asked these very questions for this case, and you will be asked the same question. So don't be in any illusion. The questions may be very different. Further, the number of questions are not fixed. It depends on how fast you reply. More the number of questions you have answered, the more the marks you get. But if you are taking undue time in responding to the question, well, you are losing out on the possibility of scoring more marks. That's the time schedule for the DNB examination, 8 to 8:30. There's reporting of the candidate, assembly attendance. Then 8:30 to 9, the candidates are brief, distribution of the answer sheets. The candidates are made to sit in a hall as per the roll numbers which are displayed there. 9 to 11, there are OSCE which are run from the National Board of Examination Command Center in Delhi. There is a short tea break after that, those 20 OSCE questions. Then 11 to 15 to 1:30, there is clinical case examination, 2 cases that I said. Then, from 1:30 to 2, there is lunch break, and 2 to 5, ward rounds and vivos. So that's approximate time that is there for DNB examination. What kind of questions? Well, questions vary with the intensity of the difficulty, degree of difficulty. They may be very easy. It's so easy that you might feel what a question to ask is so simple. Well, don't be in illusion. Subsequent questions may be more and more difficult as you keep on answering. Easy questions, example is the ASA grading, allopathy grading, fasting guidelines, things like that. Moderately difficult comes to like, pathophysiology of failure in COPD, management of eclampsia, causes of desaturation in the postoperative unit. Then comes very difficult, opioid receptors, role in transmission of pain impulses, physiology of one lung ventilation, why obese patients are more prone to hypoxia during induction, things like that. I'm just giving an example. Challenging opioid hyperalgesia mechanisms, chemical structure of different drugs, what was in the transmitral valvular gradient in MS, some things like that. So as you keep on answering, the difficulty degree of the questions goes on increasing because the examiner is giving you more opportunity to score higher. If you answer easy questions and you stop there when there are difficult questions, well, examiner knows his level of the knowledge is just up to that much. But if you keep on answering difficult and then more difficult, then the examiner it gets some message that yes, the student knows the subject well. Examination center for MD examination is at the place of work of the student. Always, nearly always. Or it will be in the same city. Like in Delhi, students who are working in one institution may be going to another institution for examination. So it will be there in the same city, if not in the same center. For DNB, it is never at the place of work of the student. It's not even the same state where the student is working. Further, the examiners also are not from the same state as the students are. If the student is from Kerala, the examination may be conducted somewhere, say Ahmedabad, it may be in Guwahati, it may be in Bhopal, it may be anywhere. Examiners also will be coming from outside the state of those students. Now, what do you do? This is relevant for DNP examination particularly because you may be new to the city examination center. You are not familiar with the city. You haven't seen the examination center. So in that case, do a round of the examination center an evening before, since you will be new to the city. Even if you know that, it's a good idea to see the examination center a day before when you reach. Or else, you send someone who is accompanying you to do a recce. Well, husbands will be handy for ladies. So anyhow, you must know exactly where you are to reach and how much time will it take. Collect all the material to be carried an evening before and sleep early for the night. It's important, very important. Remember one thing, the cost of lack of sleep is always higher than the little knowledge that you may possibly gain by staying awake all night. Don't go for the examination with groggy eyes, heavy head, spinning. Examiner asks you some question, you take a long time to think of the answer. It's all because of the lack of sleep that you have had. On the day of the examination, dress gracefully. Well, I don't want to say what means graceful. Simple dress, wear an apron, put a slip bearing your roll number. What to avoid? Display of tattoos. Well, if your whole arm full of tattoos and you're wearing half sleeve shirt, well, examiner gets the impression that this man is into good things of life and his interests are beyond the subject as well. It doesn't give a good impression. Stained clothes, ripped or tattered clothes, and words on clothing. If you have words on clothing like this, well, I won't say anything more. This can be a possible outcome. What things you need to avoid? Clothes that reveal more than they conceal. Weather inappropriate dress up. It's a peak of winter and you just walk in with a half sleeve because you want to show that you have big, well maintained body, good muscles. Avoid a dirty, crumpled apron of a colleague whose name you are trying to hide with the tape that you put up on the apron. So don't do that. The apron, it's particularly for the national board, they do not suggest that the name of the hospital be displayed or the candidate is coming from which hospital, where is he attached. That's not to be shown or not to be revealed. Avoid loud colors and printed fabrics, which may look bizarre. at least out of context to the situation you are in. With regard to the physical appearance, no body studs. If you have them, remove them. A conspicuous shaving cut or a funky hairdo, which sometimes is seen. Avoid too many bangles because that's quite a bit of distraction. Remember the cardinal rule. You don't want the examiners to remember you for your appearance, but for what you said and how you said. That is the crux of the matter. Arrive on time. Important, 15 to 30 minutes usually is good enough. Now, don't arrive to the examination center with a sack full of books. You will not have time. One, two, if you open the books, you will confuse yourself more than what you were before. So don't touch the books at that time. But not to carry along. Cell phone, iPad, you will not be permitted inside. Coffee flask, large stacks of food, well, that would not be required. Chewing gum, etc. If you are a smoker, avoid it before going in. What more to avoid? Large quantity of jewelry, don't display, all that. Coins in the pocket that may tinkle as you move. And if you love these signet shapes on your fingers, at least I would say that unload your fingers for that particular day. Physical appearance should be taken as a package of the product. Now, how to start the day? Examiners usually have a briefing session before the start that they call the students. They give instructions, what to do, what not to do. They introduce themselves. This is more important for DNB students because students do not know anything about the examiners, who is who. They explain the process. Cases are allotted by a draw of lots for MD examination. For DNB, the system is different because you have certain cases and the same cases will be seen by everybody. For MD, there is a draw of, it's a kind of lottery system. You pick up a slip that bears some number or the bed number of the patient, which is your case to examine. And after this is done, the non-examiner coordinator takes over. You are taken to the ward, or if you are there in the ward itself, you are shown your long cases on bed number 1 and your short cases on bed number 7 and bed number 9. So every candidate is given that information. Half the students generally take long case first and other half take short. This is for MD examination. Now, how do you conduct a general physical examination of a male patient? It's important because otherwise the patient will become uncooperative. Just say gentle hello to the patient to show your friendly approach and to win his confidence, and tell him what you will do. Ask him if you can examine him or her. Seek his cooperation. Put him in a position of comfort. Make sure that he is sitting comfortably or lying comfortably. He is not in not in an awkward posture that he may feel pain or he may feel discomfort. And if your language doesn't match, this is for DNB students particularly, if your language doesn't match, seek an interpreter. MD students usually have no problem. Now, what about the physical examination of a female patient? Respect her privacy. Ask for a screen if you are examining. Respect her religious beliefs. You must take a lady colleague or a volunteer to be with you while to make the patient comfortable. And to seek answers to intimate questions, seek help from the lady colleague. And always seek her permission before you expose for examining that patient. Now, often it is seen, if the patient is educated, he will tell you the diagnosis. Don't feel a stroke of luck. Don't take it as a stroke of luck. There may be some catch in it. Politely thank him for his help. If the patient has told you the diagnosis, sir, I have mitral stenosis for the last 5 years, don't take that. Politely thank him anyway and say that you would still like to examine to ensure that nothing has been missed previously. Now, what have you done? He will happily cooperate with you now because he thinks that this gentleman is doing a thorough work. He will assess me again that nothing has been missed, and you win a lot of respect from that patient. Remember, for him, you are some doctor, but for you, he is the patient who can make a difference to your life and to your career. History taking is an art. Let the patient speak first, and then lead him to the information that you actually are looking for, and then go for physical examination. It's very important to make a good first impression. Now, how do you make that? You are under judgment the moment you enter the room, and how you look and how you conduct yourself is often the precursor of things to come. First look, and the examiner has a very, very, gross impression of you. You will never get a second chance to make the first impression. So it's important for you, when you are seeing the examiner for the first time, you should have a good impression of yourself. How to make it good? Simple, normal, routine courtesies that you should perform. Seek permission before entering the room. Enter with some air of confidence. Avoid footwear that is noisy, high heels. Don't TikTok into the room, and that TikTok is heard two, three rooms away also. No, not like that. No squeaky sounds from the shoes. A gentle smile and good morning is a nice way to start. Do not sit till you are asked to do. Simple courtesies. Start only after you are asked to do. How to present your case? The case presentation should include key points in history, clinical examination, investigations, differential diagnosis, and management. Remember, case presentations make the maximum impact on your credentials to get through. A good presentation is a skill, and this differentiates a topper from a mediocre student. So it implies that you should have more and more practice of presenting cases before your final examination. The more the cases you present, more confident of yourself you are, and more questions you know what can be asked for that particular condition for which you have presented that case. For long case, generally when the cases are allotted, you are given 1 hour to examine all the patients. That includes 1 long case and 2 short cases. You can divide the time as per your own choice. Generally half an hour for a long case, and then 15 minutes for 2 short cases. 1 hour, after 1 hour, you are called in turn-wise for the viva. You have to take full history and examination for the long case, and this should be recorded in detail in the answer sheet, because you're likely to miss some points which you don't want to, which may have bearing on the case discussion. And this is usually followed by viva for about 30 minutes for the long case, and almost equal amount, 30 to 40 minutes for the long case, and almost equal time for both the short cases. So if it is 30 minutes for the long case, and it would be 15 minutes each for the short cases. The long case is usually considered difficult. Why? There is unstructured questioning. There are some easy patients, there are some hard ones. Some cooperative patients, some are not. Case specificity may not be your favorite. You may be very good in pediatric anesthesia, you may be very good in neuroanesthesia. Case you get is cardiac anesthesia, or it is obstetric anesthesia, or it is geriatric anesthesia. So the case specificity may vary. Well, don't rule out the possibility of examiner bias. Some examiners are quite stringent, and it's also a test of your communication skills. Short cases, as I told you earlier, they have an obviously visible diagnosis. You don't need to work much. Cleft lip, hydrocephalus, cataract, and you are not expected to write in detail on your on the sheet that you are given. You can note down some key points so that you don't forget when you are going to the examiner. Viva for short cases usually begins with what is the diagnosis, and from there on the questions follow. Now, once you have examined your long and short cases, you haven't appeared for the vivas yet. Once you are done with examination of the cases, you have written everything for the long case, it's very important that you have some sort of a mental preparation before you are called in. Keep off the notes and the friendly helps. Don't ask for answer to this. Don't ask for anything else. Just cool off, sit quietly and wait for your turn. When you're called in, do greet the examiners with a gentle smile. These are simple courtesies. Sit upright and look alert and interested. Don't fidget or slouch or crack knuckles. Some have habits of pulling your fingers, cracking knuckles. That's not a good time to do. The sequence of case presentation, I'm sure you're all familiar, but just to repeat again, chief complaints come first or the presenting complaints. History of present illness comes then, history of past illness, family history, personal history, medication history, general physical examination, systemic or the local examination, the summary, probable diagnosis, and differential diagnosis. These are the various components of the case presentation that you need to confine to. And it's more true for the long cases. How to make the presentation? Presentation should be based on facts. Use simple language and articulate very clearly. Don't use complex, difficult words. Don't be a Shashi Through for the day. No jargon. Avoid being verbose, rhyming, or repetitive. Punctuate the presentation briefly in between. Presentation should be reasonably fast and polished. Give the impression that you understand the problem and know what you would like to do. After the presentation is done, summarize the whole case. Start with the chief complaints, salient features in the examination, and then the provisional diagnosis. And the last statement before you finish up the case is, sir, based on the history and clinical examination, my provisional diagnosis is this. However, I would like to rule out these conditions. Now, this is how it should be done. And I'll give you an example of it in brief. Just summary of it. A 70-year-old male presented with chief complaint, the patient has presented with obstructive jaundice. So you will sum it up. A 70-year-old male presented with chief complaints of dark-colored urine, clay-colored stools, increasingly yellowish discoloration of the sclera, and excessive itching. All these are suggestive of obstructive jaundice. Elderly age, decreased appetite, marked loss of weight, late onset of pain, and hard nodular mass strongly suggest the possibility of malignancy. Sir, my provisional diagnosis, therefore, is obstructive jaundice, possibly due to malignancy, maybe of gallbladder origin. However, I would like to rule out, say, the carcinoma of pancreas, cholangiocarcinoma, or whatever you think. So if you have presented the case this way, summed up this way, I'm sure the examiner has a very positive impression of yourself and he would start the discussion with the intent of giving you more marks because you have done a very good presentation. Now, once the presentation is completed, now it's the examiner's turn. Listen carefully what he says, what he asks. If not clear, politely request for repeating the question. And don't fire off in the dark. Be brief and to the point. And don't go on a monotonous speech mode. How to answer? Be sure what you want to say. The dynamics of the tongue and your brain should match. The two should be connected. Use simple language, simple English. And you are not confident with English, ask permission to speak in the native language, at least part of it. I'm sure the examiner will permit you to do that. Be sure you taste the words before you spit them out, because once you have spoken, no going back on it. Viva stations, let's say the drugs first. Usually there are a limited number of drugs which are on display in a tray, about 15 to 20. I would suggest that prepare for 3 or 4 drugs very thoroughly, because the examiners often give you a choice. Pick up any. And if he has given you a choice, thank him for that and pick up the drug that you want with the remark that, sir, as you suggest, I'm picking up this drug. But avoid picking the most common drug. Now, if you are looking for, looking in one tray, then you're looking in another tray, then you're looking in another tray, you don't find the drug that you find, or eventually you find it, and what you come up with is propofol. Now, that's a drug which the examiner has heard so many times. He's already sick of it. Do not avoid the most common drug. Don't go for hunting the drug of your choice. Pick up a drug which is not very routinely used and not very, very rare also. So it should be somewhat in between. Because if you pick up a drug like that, the examiner starts with a very positive step right in the beginning. Okay, he's beyond propofol, he's beyond succinylcholine, he's beyond ketamine. So he knows, he's probably knowing more than most other students. For NSA machine, most commonly asked questions are safety features, 3 divisions of the of the NSA machine, pin index safety system, flow meters, vaporizers. Although modern day machines usually they are different now as compared to what we grew up with these NSA machines, but still the questions remain the same. The next station is resuscitation. This is a must-know area. There are no compromises here. The examiner is not going to forgive you for any wrong that you do here because it concerns the life. Site of compression, rate, depth of sternal depression, you must know. There is no room for error here. Defibrillation, how will you do it? How much energy? Cycles of 30:2. Viva stations, ECGs, X-ray, capnographs, ABG reports. ECG, you should be able to identify the common conditions. So usually, the sinus tachycardia, sinus bradycardia, arrhythmias, or MI. So the simple ECGs are usually kept, not very complex kind of things. However, there may be 1 or 2 difficult ones. If you have answered the simple ECGs, then he may give you a difficult one to give you more marks. X-rays usually relate to airway, lung collapse, pneumothorax, hydropneumothorax, cardiomegaly, things like that. COPD, like that. Capnograph, restrictive and obstructive pattern. These are usually there, and you must know the capnographs. What do they represent? ABG, acidosis, alkalosis, metabolic, whether it's metabolic or respiratory, whether it's compensated or it's not. I think you all are quite familiar with it, but yes, you must answer to the ABG with regard to whether it's acidosis, alkalosis, and metabolic or respiratory, and why you call it as compensated or not. In the DNB examination, often there is one more table that is to test the communication skill of the student. There is one actor who is representing as the kin of the patient. You have to ask him, you have to convince him before taking the consent of the patient to take consent for tracheostomy. Patient is unconscious, is not able to give, will not be able to give consent himself, or break the bad news to the family. There's been a demise, the patient has died. So how you're going to break the bad news? Counseling for organ donation or consent for immediate surgery that's required for the patient. So you have to talk to them softly, convince them that this is a need, this is a problem, and that's why we need to have surgery. So this communication skill is important for the student, because you know that not very not very often though, but still it does happen that from time to time there are doctors who are working in the emergency. They are attacked by the patient's attendants that their patient has been neglected. So it is basically to ensure that there is a good communication between the doctors and the patient's attendants, so that they are aware of what is being done. Now, there needs to be some sort of a matching between the skills to the requirements of the examination. What does the examiner need from the student? He needs a good knowledge base, Clinical skills, ability to apply those, ability to form an action plan in the management of the patient, to be aware of his limits, justification of the actions that are taken, good communication, to believe in teamwork, leadership in time of crisis when the patient has suddenly collapsed. You got to lead the team in resuscitation, and initiative to work. And you need to pass the examination. So that matching has to be there. As I told you earlier, listen to the question very carefully. If you are not clear, you must seek the clarification. Otherwise, you will mess up the whole thing, and that will go against you. Be alert to the examiner's body language while you are answering. Speak clearly, show enthusiasm to deal with the given situation. Do not take undue time to respond because you're wasting your time. Time is limited. It's the same time for everyone. If you don't know the answer to the question that is asked, just concede so that he can ask another question which you would be knowing. Now, if you don't know the question, there are two options. One is you say, sir, I don't know. The other is, I'm not able to recall. Now, which one would you prefer? I think you will go for the second one. Now, what does this suggest? I'm not able to recall. That it implies that you have read it, but you're not able to recall. Maybe, under some sort of stress you are, and you're not able to recall. If you say, I don't know, sir, that suggests that you probably have never heard of it or you never read it. So the second option is a better answer. Avoid answering with a guesswork. If at all you do that, you have a guesswork, defend yourself by adding, sir, I think it is so, but I don't commit it. Now, in this situation, if your answer is right, examiner will give you full marks. If it's wrong, he will not take a bad note of it. So that's being a bit of a diplomat when you are appearing for the exam. Keep your answers appropriate, to the point, and brief. Do not just start off for a long monologue. Remember, you get marks for the answers to the questions asked, not for the answers that you have already provided for the questions which are never asked. So you won't get any credit if you go on speaking on the same thing. Also, be very careful. Do not avoid offering another answer as an alternative to what is asked. Like in this, the caption is, I could not repair your brakes, but I made your horn louder. Now that you don't have a trade-off with the examiner. While answering, lean forward and show interest. Keep your hands away from the face. If the examiner has asked and you put your hand on the face, well, that's a very, very negative, expression. Don't sit with your arms folded across your chest. That's a very defensive posture. Not a good idea. Make an eye contact, but don't stare at the examiner. And softly smile occasionally, but don't carry your smile beyond the molars. What creates a bad impression? Poor knowledge of the subject, lack of preparation, negative attitude, evasive, using excuses. I couldn't examine the patient well, sir, because on the neighboring bed, there was a child crying loudly. So don't offer any excuses. Lack of interest and enthusiasm, failure to give clear answers, failure to defend your diagnosis. That's the important one. You get to know of the diagnosis from a friend here and there, and then you keep on, fitting everything to fit into that diagnosis, which is not a good approach. Lack of management plan or failure to defend, and of course, the poor personal appearance. Do not overtalk. This includes straying from the point and monopolizing the Viva time. Stay stuck to the particular point, the question that the examiner has asked you. A good interaction is a dialogue. It's not a monologue. Do not display arrogance or superconfidence. This is absolutely unprofessional. It will put off most of the examiners. Restrain any distracting physical habits. Do not complain about the peripheral items. Do not make negative references to others, including your own workplace. Sir, at our institute, it happens like that. So don't give that kind of excuse. You need to match your communication with your confidence. Listen carefully to the question, avoid interrupting the examiner, try not to use jargon in your answers or questions, and do not toot your answers again and again and again. that will put off the examiner. Dealing with the nerves is, being nervous is very, very normal. It really harms your chances. However, excessive nervousness can go against you. Some people tend to be overly talkative when they are nervous. So if you fall into that category, do not go off tangent. Stick to the question being asked and answer it as concisely as possible and no more. Do not, if you do not know, politely concede and quit. Now, sometimes the examiner gives you lifelines. If he has given you one and you have come to the correct answer, acknowledge it gratefully. Sir, yes, sir, I was about to say that only. It's being a little bit of diplomatic, nothing else. Sure, sir, thank you so much. Okay, thanks for correcting me, sir. Okay, that's a better way, sir. Sure, I would like to do as suggested by you, sir. Yes, sir, that's a better idea. I fully agree, sir. In fact, it was on my mind. Refusing the lifelines. Well, no, thank you. I would better not. No, but thanks for the suggestion. No, I would rather not do that way. I'm sorry, I can't. No, but thanks for your hints anyway. Sorry, I'm not in agreement with you. Thanks for your suggestion, but I would like to do it my own way. And it is quoted in Miller, page 1129, para 2. You have signed your death warrant, almost. So while accepting the hints are the lifesavers, refusing them can be killers. Never plead, cry, mumble, brag, talk too much, be too giggly, laugh or too loud, act superior or inferior, argue, overconfident, and criticize your colleagues. And never demean your seniors or the institutions. Very important. The common mistakes that students often do: inability to apply knowledge to the clinical situation, adapt to the changing clinical situations, defend decisions in a convincing manner, transmit sufficient information, indecision or incorrect decision, and the faulty judgment. Now, blunders to be avoided. Persisting to prove the diagnosis that you have come to know of. Defending the indefensible. Implanting findings. There is nothing that is suggestive of the finding that you are trying to put in, but you are putting it in because you want to reinforce that this is a diagnosis and that you want to prove the diagnosis is correct. Negating the examiner, that's another blunder. So good to get a good score, present yourself well, look graceful, act a professional, develop good presentation skills that you can do only by doing more and more, adopt a systematic approach, listen carefully before you speak, keep your answers to the point and be brief, communicate well, avoid a confrontational approach, and avoid overconfidence. This is Bertrand Russell. He said the whole problem with the world is that fools and fanatics are always so certain of themselves, and wiser people are so full of doubts. I will end with the anecdote on height of confidence. Once many professors were were called, and they were asked to sit in an aeroplane. After they sat, they were informed that the plane is made by their own students. All of them ran out, except one. And people were thinking as to why he is there. People asked him the reason. He said, if it's made by my students, it will never even start. Well, I don't think it's your case. I think every teacher who has taught you will be confident of you, that you will do well in your examination. All the best as you journey through this examination. Keep your head high and see yourself in excellence. And we will be congratulating you after your examination on your success. Thank you so much, and God bless you.
Thank you, Baljit,
Thank you, sir.
for the excellent and exhaustive presentation. That is a wonderful presentation.
Thank you, sir.
I'm sure everybody is pleased to hear and is benefited. And students, or say my friends who are listening, do you have anything else to raise up and clarify the point? Anything else you want to know about the examination? The examination pattern, even in India, is changing. Say in another 2-3 years, you will not be having the long essay type of examination. It will be short. And more things are going to come on that particular way. And I request any of you, if you want to inquire any particular matter, please go ahead.
Our president can add on. She's been examiner for so many years herself, and a very loved person, I must say that.
Yeah, Jayeshi is a very popular examiner.
It's
Very
my
popular
turn
examiner.
now, Baljit, to praise you. And
Yeah,
an
please.
excellent webinar. You know, somehow I've always been very keen to hear your lecture because I've heard about it so many times. And
Thank
I'm
you,
so happy that I could be a part of this today and I could hear it. And all my students have logged on. I told them that it's a very, very important. So, सबके messages are, ma'am, we are on. So
Thank
that just speaks of what your standard is. And
Thanks.
students see the tips that have been given by Dr. Baljit. They are like pearls that you must remember them and practice them, and you're guaranteed pass.
Thank you, ma'am.
Thank
Thanks.
you so much, Baljit. Thank you, Dr. Radhakrishnan.
Thank you. Sanesh, are you there, Sanesh?
Yes, sir. Yes, sir.
Yeah, you like to comment anything?
Nothing, sir. Nothing to add, sir. Thank you so much.
Anybody wants to put up any questions or any clarification?
Chat box is there's nothing in the chat box.
No, sir. No questions in chat box.
Oh,
The only thing what I would like to say is that
so
the examination pattern in India is slightly different from international examination. As such, in the major developed areas, there is no clinical examination as such here. They are going away from the clinical examination part. Instead, a type of question is given, the same question given to all the candidates, and everybody is going to answer on a particular problem. That is the best. Anyway, we have not introduced that system so far. Very soon we will be introducing it. As far as I know, it is going to be done from 2027 onwards. That means after 5 examinations, probably that is the one particular pattern which is going to be adopted. That is what I hear. And we need, you like to inquire anything? Vinay, you can
Yes,
also.
sir.
Yeah, please.
Sir, I had just discussed one thing with Baljit sir before we started the webinar, that theory is all about, theory has a slightly more significance in DNB examinations, because only after passing this we can go ahead with the practicals. That theory is all about how we present our answers, and practical is, as sir said, how we present ourselves. That is the gist of the entire preparation aspect from resident's point of view.
absolutely right. Absolutely.
The only thing what I would like to tell to the listeners is, please be not harsh with your patient, even if the patient is not cooperative. If the patient is not cooperative or you cannot get along with the patient, tell your interpreter or the particular helper in the examination hall, sir, I am sorry, I am not able to go along. They may find some measures, but never quarrel with the patient who is brought for you. That's only one thing which I would like to say. And as far as possible, do not guess and answer. These are the only 2 things which I would like to say, other than what Baljit was elaborately telling. Since there are no other clarification to be raised, I request President ICA Dr. Jayeshi to say the formal vote of thanks to our Baljit.
Ma'am, you are muted. Ma'am, kindly unmute yourself.
Jayeshi, you are muted.
Yes.
Yeah.
Hello.
Yeah, you may give the water thanks, please.
Oh, okay. So it's my great pleasure to propose a vote of thanks for today's webinar. And we are really very, of course, Dr. Baljit is a backbone of the ICA. But I have to thank him. He's so busy. And today was a special request that he should he should speak on this webinar. So thank you very much, Baljit. And as I've already said, that the students,
You don't
you
know
all
how
have,
I coaxed him.
I, and the students, I'm sure you all have benefited so much. I can see all the compliments that Baljit is getting. And it's really indeed lovely tips that will go a long way. Thank you so much, Baljit. Thank you, Dr. Radhakrishnan. Thank you, Vineet, Sanish, and
Sanish,
Rimpa.
you can keep me, Baljit, and Jayashi in the loop and all of this. Kindly
Yeah.
excuses for some sort of confusion.
Thank you and good
Yeah.
everyone.
Okay.
Thank
Okay.
you so much. Thank you, Rim. Thank you.
Kindly keep us. Rimba,
Thank you so much to all the dignitaries for the wonderful deliberation and the informative content. So with all your permission, will be ending the session over here.
don't switch off, please.
Thank you. Thank you, Rimpa.
Now, Jayashi,
Yes.
I saw that I was not knowing that Manjusha was given a chance. In that
Yeah.
case, my choices are Anju Grawal, Ludhiana, ex-Ludhiana. Somewhere in Punjab, she's somewhere in Punjab.
Yeah.
She's not in the old institution.
All India Institute, Bathinda, sir.
Yeah, Batinda, correct, Batinda.
Yeah.
Batinda. Yeah,
Ames
she's in
Batinda.
Batinda.
Yeah.
Anju, first choice, second choice, Indrani, third choice, Sushila, Taksak. So one out of these three could be the orator. That's my choice. Baljit?
Sir, I would like to have a relook because Madam was saying that she will send a list of the previous awardees of the oration. So let's
These people never came. Indrani never did.
No.
Anju never did. And
No.
Sushil also.
What Baljit feels he might be having some other name and he just
Yeah,
wants.
yeah, you can. Absolutely no problem. That's your choice too.
I'll send it right away tomorrow.
Yeah.
please, ma'am,
First thing.
take your time. And the other thing is,
Yeah, I'm being open on the matter.
the other thing is that is Anju Garewal a member of ICA or not?
I'll check, but I think she is because she's been coming for our all ICAs as faculty. She is, but may confirm.
She's a member.
Yeah.
She's a member. Well, then
She's
we can't have a better candidate than my vote also.
She's a member. She's a member.
My vote goes for her. I'm in agreement with you,
I'm
sir.
fine.
Yeah.
I'm fine. Oh, absolutely fine.
तो उसको आप देख लो अगर कोई मीटिंग ऑर्गेनाइज करके आपने कहना है कि कोई डिसीजन लेना है तो आप ऑनलाइन एक मीटिंग या ईमेल से डिसीजन भेज दो
क्यों ठीक है
yes we are in agreement with this decision
कल ही भेज दूंगी मैं हाँ जी I'll do that.
You can give her a call and tell her.
That, yeah.
Will you mind to accept her?
Yeah.
Yes, madam can give a call and because she's quite busy with organizing.
I know.
As far as CP, she called me up 2-3 times ke, sir, aapne aana.
That's over, I think. RCCP conference.
Yeah.
No.
Yeah.
I could not, I mean, I'll not be able to join because I have to go somewhere else. So I, very politely, I said, I'm sorry, my apologies. I'll come.
Good. You presented it very nicely.
Now I'll speak to her and I'm sure she'll agree. She has attended all our ICA conferences whenever she's invited. So I'll check out on her ICA membership, which
I could not put a rating
she
on
is.
it.
Yeah.
I said, I'm sorry, my apologies. I'll come.
We made her when we were doing a
it
midday
telecast through
conference.
the
What's
sir,
going on?
sir, this is going live through the web page, sir. We'll close the meeting.
Close it.
Yeah, I asked the lady to close it. Yeah.
She should have done that.
No, because I checked the web page. It's going live.
Then I'm so sorry, Sanish. I
Alright.
request her to close it.
Yeah.
Yeah.
Let's go out from the.
Is it
Okay.
still open or closed?
It's still open there. So.
Still open. Okay, then we will wind up. Okay, thank you. We'll have it.
The discussion is over. Okay, good night. Bye bye.
Yeah. Whatever damage is there, that's done.
Goodbye.
Yeah.
You were asked to disconnect from others.
I requested her.
Oh, that, sir. Rimpa should have done it.
Probably she didn't understand that way.
She should have.
Anyway,
Okay then. Okay.
that's
good.
what thing happens sometimes. Okay, anyway, there is nothing secret in all these particular matter. Yeah, there is absolutely.
Still. Good night, sir.
Thank you. Thank you, Baljit, once again. Thank you.
Good night. Good night.
आपके द्वारा अध्ययन किया गया नंबर नेटवर्क कवरेज क्षेत्र से बाहर है। कृपया कुछ समय पर
Thank you everyone for the wonderful session. So with all your permission, I'll be concluding the session over here. Thank you so much.